Welcome everybody for today's webinar. It will be about the COVID-19 therapeutics update for family medicine. I'd like to welcome Dr. Paul Ryan. He's Assistant Program Director for Family Medicine Training Scheme, and he's qualified pharmacist and he's the lead of ICGP Therapeutics. So welcome, Paul. I think Brian, you have something to show before we can start?
Yes, Ahmed, and just to say your audio is coming across a bit crackly. I don't know if you've got headphones or something you can use, because it's coming across quite broken up. If you can move on to the next screen there, Paul,
no problem.
Thanks. Just to indicate that today we're going to try out a new feature, which is in your participants list. So along the bottom of your Zoom screen, a button called participants. So if you can open that, and Paul, you make sure and have it open as well, please. Basically, we can indicate at the bottom of that list, you'll see yes, no, go slower, and go faster. So if you find that Paul's speaking too fast to understand, or if just the content you want to slow down and cover it in more detail, then click the go slower button. Or if it's too basic and you'd rather rush through it more, then go faster. And if Paul asks questions, yes, no, then just tap those green and red buttons, the yes, no buttons, as a quicker way to proceed through the content. So we'll try that out today and see if it allows us to move that bit more efficiently. Okay, so over to you, Paul. Thanks.
No problem. And Brian or Ahmed, if there's anything at all, if you're seeing something that I'm not, you just interrupt away. Very informal. Do you know what I'm saying? So there's no problem. I don't ever mind that. And we have the poll. Brilliant. Lovely. Great stuff. I'm delighted to be here. I'm delighted to give you another talk. Salam alaikum, everyone. I hope you had a lovely Eid break. Now, I am, so I'm going to talk about a few therapeutic topics today. And I'm conscious I want to not go too fast. I have a natural tendency to talk very fast, so I'm going to make sure to speak slowly today. I really want to make this talk relevant to you today. So Ahmed was very kindly shared the protocol, the Saudi protocol for patients suspected of or confirmed with COVID-19. And obviously I'm going to focus on the therapeutic aspects of this protocol. But if so, and what I've done is that I've circled sorry, no, I'll just move this up. So I've circled specific statements in it, and in the protocol, and I'm just going to give you the evidence base behind these statements, why you should, first of all, why we should not use hydroxychloroquine or chloroquine as a treatment for people with COVID-19. These statements have been put in here on purpose, and I'll just give the background to it. Here in Ireland, what we've noticed in March, when all of this COVID pandemic started in Ireland, was that there was some doctors, some GPs actually prescribing, thought they were doing the right thing by prescribing Plaquenil, which is the brand name for hydroxychloroquine. And it was based on, now thankfully this is not happening anymore in Ireland, but at the time, in the midst of the pandemic and the panic that is associated with these pandemics, is that you have to try and remember to be scientific and question the evidence and question the statements that come out from these recognized bodies. So just to give a bit of background about hydroxychloroquine or Plaquenil, it's a disease-modifying anti-rheumatic drug. It's used, we use it for rheumatoid arthritis, for discoid lupus erythematosus, and SLE, so systemic lupus erythematosus. So, and it's a very safe drug, has been used for years. Okay, we also know it's an anti-malarial as well. On the 17th of March, there was a French study which was published, and it had 36 participants in this study. 20 of these participants had hydroxychloroquine or Plaquenil, and 6 of this group received azithromycin, which is an antibiotic, a macrolide antibiotic. So the results actually looked very good. If this was all the information you had on this study, you would actually say, my God, this is a very good drug. And what it showed was that at day 6, only 12.5% of the control group were clear of the virus. So the control group, the group that did not get the hydroxychloroquine. But if for the group that got the hydroxychloroquine, 57% of this group were clear of the virus. And if you added azithromycin to the cohort of the group that you gave hydroxychloroquine to, 100% were clear of the virus. So if you were just left with that information, you'd say, my God, that looks great. And what you'll see in some of these studies and some of these publications is that if you were to just glance at it, you'd say, okay, that looks very good. But you have to just go back to basics. And I go back to basics because, as Ahmed even mentioned at the start of this talk, every day there's more studies coming out, and there are, about this drug and this antiviral and this other immunomodulator. And you just have to question to see what actually was the study. Was it an observational study? Was it a randomized control trial, or what was it? So there was a number of limitations to this Plaquenil study. Number one, there was only 36 participants, which means that it was underpowered. The sample size is underpowered to provide conclusive results. So what happens when you have a study with very few participants is that you get exaggeration of effect sizes and false positive results. In order to get to achieve an 85% power, you needed at least 48 patients. So the second point was that 6 of these patients were lost to follow-up. Okay, and this was a large percentage of the patients. And there is an old saying in epidemiology that states that it's when you do any randomized control trial, just to break it down, you've got a drug A, you have a cohort of the population, so you have a certain amount of people that you want to expose the drug to. You randomize them totally, so you should not pick which ones should get the drug and which ones can't, because that introduces bias. But you give them the drug, the cohort, the certain drug, and you follow up. You have to follow up. So once you randomize, you always analyze. So once randomized, always analyzed. So that didn't occur here. So they got the hydroxychloroquine, and we don't know whether they improved or not. So they were lost to bias now, or lost to follow-up. So this may have been totally unintentional by the authors, and I'm not saying that it was done intentionally, but at the same time, it is a big limitation with this study. And by me going through this study with you, next week when there's another drug out stating that it's very good for COVID, you can just break it down to these main points, So when you do not perform an intention to treat analysis, so when you don't follow up with the patients that were exposed to a certain drug, well, then that may introduce bias. So it's very important to recognize that. It wasn't a blinded, nor was it a randomized control trial. So there was a potential for allocation bias. So we don't know whether, when you have a group of people, you should always randomize the group of people to the drug, or randomize for them not to get the drug. But it has to be, you can never pick the people that you want to go on the drug. And this, you could have picked the people. This was, there was a potential for allocation bias with this, because it wasn't a randomized trial, or nor was it blinded. And the final thing is the outcomes. You look at the outcomes, and this is actually going to come at the end of the talk again, because there's recent studies from the Lancet and the New England Journal of Medicine that I'll allude to at the end of this talk, and it's the same issues again. Just like, what is, so when they say a drug works, what does that actually mean? So with this particular study that was published in March, the viral PCR status at day 6 was the primary outcome. Okay, so that means at day 6 they did PCR, and which meant that what about day 7, day 8, day 9, or what about 2 weeks after the event, after getting the hydroxychloroquine? You know, was there, and did the person live longer? Did they have less comorbidities? What was the actual outcome? But this was all it was. So with the PCR status at day 6 as the primary outcome, the trial lacked medium and long-term follow-up data. So, and a specific example, an issue with this was that one patient actually tested negative for the virus on day 6, but then subsequently tested positive on day 8. Okay, so it's like it wasn't a good primary outcome. Okay, and these are the basis of all trials that you have to take into account. So I have a question for you. My first poll question is: does hydroxychloroquine increase the QT interval? So I'm going to launch the poll there. So do you think that hydroxychloroquine, this is totally anonymized, but do you think it increases the QT interval? Oh well, there's 25% voted. Nearly, even if we can get over 80%, is great. We're at 40% now. So that's very good. I'll give it.
Yeah, for those who don't know the way, just press on participant. On the right side, it will show to you some buttons written yes, no, go slower, go faster. The poll and yes and no. Just press yes or no.
Great. So yeah, the 60% of you voted now at this stage. So and 95% of you are correct, and it does increase the QT interval. And this is the big issue with hydroxychloroquine, that it does increase it. So I'm just going to put this away there now. So it does increase QT interval. And why is that relevant? And I'm going to just talk about azithromycin for a second. Now we see azithromycin is a macrolide antibiotic. It also actually has anti-inflammatory effects, and this is how it's used in people with frequent exacerbations of COPD. So it's not used for its actually antimicrobial effect. It's usually used mainly for its anti-inflammatory effects in this. So some patients in family medicine, in primary care, are on this 2 or 3 times a week. But this particular drug was also incorporated. It was brought into this study. So there was some GPs felt, or some primary care physicians felt, family medicine doctors felt that should I also be prescribing azithromycin, because this is what the study said. So I'm just going to this is the poll question 2. So I'm going to launch this poll. So I have a question. The question for you is: does azithromycin prolong the QT interval? Okay. Well, you're getting very fast. Now it's very interesting, because when I do these talks in Ireland, it's the same. Similar percentages have answered, you know, correctly or incorrectly. So I hope that you get something from this talk. But this is one of the points I wanted to make with this talk, is that yeah, so over 60% you voted, so that's great. So I'm going to share the results. Okay, so 60% of you are correct, and are correct in that azithromycin does prolong the QT interval. Okay, so when a respiratory consultant usually are the people in Ireland who start people on azithromycin, but you normally need an ECG prior to starting azithromycin for that reason, because it prolongs the QT interval. Now, this is from the American College of Cardiology, and this is a risk score for drug-associated QT prolongation. And this is actually a recent enough, has been updated recently enough. And one of the main reasons why it came to prominence, why it was updated, was because we saw right across the world, because of that study done on Plaquenil with azithromycin, unfortunately, there were case reports of people presenting into A&E with ventricular tachycardias and torsades de pointe, secondary to QT prolongation, secondary to azithromycin, plus or secondary to hydroxychloroquine plus or minus azithromycin. And the reason why they were started it was because of COVID, and there wasn't enough of an evidence base because of the 4 main flaws that I spoke about in the study. So unfortunately, more harm came to patients who would have been otherwise well. So this is why it's very important to talk about it. So this scoring system, I like this scoring system because it's very straightforward. Some of the scoring systems for QT prolongation can be kind of complicated, but with this, it's an easier scoring system. So in Ireland, I don't know what it's what the shops are like in Saudi Arabia, and I'm looking forward to going over at some stage over to you. But in Ireland, we've got shops called 7-Eleven shops. So 7 days a week, they're open from 7 a.m. until 11 p.m. So 7-Eleven is were the shops now. That a lot of them are open longer now at this stage. But 7-Eleven is an easy way to remember how to risk stratify patients who, with regard to QT prolongation. So if a patient scores 7, they're at moderate risk of drug-associated QT prolongation, and if they score 11, they're at high risk. So if you have a patient who's 68 years of age or older, they score 1. If they're female, they score 1. And if they're on a loop diuretic, such as bumetanide or furosemide, they also score 1. So that's a score of 3. If they have a heart failure diagnosis, they also score 3. And if they're on one QT prolonging drug, this scores 3. So if they're on hydroxychloroquine or azithromycin, that scores 3. Now the last two, the last score of 4 is that if they have a serum potassium of 3.5 or below, they score 2, or if they've got a corrected QT interval of greater than 450 milliseconds, they score 2. The issue with these 2 points is that before you put a patient on hydroxychloroquine or azithromycin, you'll need to do a blood test to make sure that their potassium is not 3.5 or below. And you will also need to do an ECG to make sure that they don't have a QT interval greater than 450 milliseconds. So this is in the midst of a pandemic when patients are very anxious to that do not really want to come into our practice to see us because they're nervous about COVID. So the point is that you're subjecting a person to getting a blood test and an ECG to put them on to make sure they don't have a high risk score, to put them on a drug treatment that won't work, okay, or that has not been shown to work. So this is why the statement from the Saudi Commission came out and said that not to use hydroxychloroquine, and that's the evidence base behind it. So they therefore need a baseline ECG in bloods, renal function with magnesium levels before azithromycin or hydroxychloroquine is used. So in conclusion, there is not enough evidence to state effectiveness of hydroxychloroquine in the Plaquenil in the community. Hydroxychloroquine and azithromycin are both QT prolonging medicines, so you need an ECG in bloods as there is a risk of ventricular arrhythmias. Hydroxychloroquine in Ireland is used mainly for SLE or rheumatoid arthritis. So if we had ran short of hydroxychloroquine in Ireland, that would mean that the patients would, the rheumatoid, it would lead to flare-ups, which means that we would need to put them on steroids for the flare-up. And when you're on greater than 7 days of steroids, you are immunosuppressed. So in the midst of a pandemic, so it would have been an absolute tragedy if we had ran out of hydroxychloroquine because of this study. So the EMA, so the European Medicines Agency, on the 1st of April, stated that chloroquine and hydroxychloroquine only to be used in clinical trials or emergency use programs. So that's from Europe. Then after that, on the 13th of April, the Infectious Disease Society of America published their guidance, and in their guidance, they described 2 studies which described significant QT prolongation with hydroxychloroquine. And also, there were several case reports of azithromycin causing ventricular tachycardia, unfortunately, and this had a cumulative effect with azithromycin. So the bottom line is that you only use hydroxychloroquine plus or minus azithromycin in the context of a clinical trial. So baseline and follow-up ECG and no other, and make sure that they're on no other QT prolonging medicines. So now the next thing to talk. Oh, yeah, go on. Yeah.
according now to the evidence, hydroxyquinone is not used totally for the treatment of COVID-19. If we go back to the recent history, that many people, they were amazing about the drug, and even Donald Trump mentioned in his speech many times about the chloroquine. But you know, the evidence is the master of everything. If you have the evidence, so this is the new evidence that we have to be hurry up to use medications for drugs or medications or therapeutics without evidence. This will may harm the patient. The chat doesn't have any questions. So people, if you have any questions, you can post in the chat, and I will transfer the question to Dr. Paul. Okay, can I continue, please?
Perfect. And I suppose, and Ahmed, it's I think this is what differentiates us, unfortunately, actually, for Twitter and WhatsApp and all these groups. I found personally, I'm a pharmacist 16 years at this stage, and I find it that people are not that they know more, but some of my patients think that they know more because of, we say, Donald Trump and different things. And I'm going to give out about the BMJ as well. I was disappointed in BMJ. I had a disagreement with the BMJ as well, and I'll talk about that in my next few slides. But I find that when patients come into you and say, well, Donald Trump is saying it or BMJ are saying it, then I'm there. What differentiates us, and this is why I never get personal with any figure, public figure, but it's science. We're scientists. We have to just look at the evidence base and question. When that statement comes out, say, okay, that is your opinion, and where is the study? And then look at the study. You might find, as when we were undergraduates, when you're looking at literature reviews and that, and they may not be the most exciting, but if you can just look at the evidence and just question it, that's what I always say, and then form your own opinion and say, okay, I respectfully disagree. And you'll find the evidence always comes out in the end. People panic, and I'd be very slow to prescribe any new drug like that based on what anyone says, but until I see the study and until you look at and look for any flaws in the study, because unfortunately people have died as a result of this, do you know? So and there has been case reports, and do you know, the patients trust us, so we have to look at the evidence base and look to guidance. So now I'm going to talk about ibuprofen and COVID, and I'm going to talk about my own personal story with it as well. So there was, and it's actually interesting here in the guidance that you sent me, paracetamol is the preferred agent and is rightfully the preferred agent and should always be the preferred agent, but anyone with any flu-like illness. But if paracetamol, if the person still has myalgia and still feels unwell, we'll say a child who has a high temperature, and if they're unwell, even after taking the paracetamol, well, then there is a role for, and not just not to treat the temperature, but to treat the associated symptoms like being off form, myalgia, and that there is a role for Nurofen or ibuprofen. Okay, so and it's funny because I never thought I'd be defending ibuprofen, because I give out a lot about anti-inflammatories. They cause a lot of harm, especially in our elderly population, but I actually found I was defending ibuprofen on this point. So the background to this was that there was a letter to the Lancet on March 11th, okay, and this questioned this. It was an observational study, and there is always a role for observational studies where a doctor looks at this patient got ibuprofen and he had a worse outcome, whereas that patient didn't get ibuprofen and he was fine. So you question, you say, look, and this is how science works. You look for the observation, and then you do an RCT, or you do a properly controlled study to see if the hypothesis is correct. The problem is that, and it was Twitter actually, this letter was published in the Lancet. The French minister, the health minister, retweeted it, and it caused, all of a sudden my WhatsApp went mad, and Twitter, and there was question, my God, what if I have a child with runny nose? Now can I not give them Nurofen or what? Because you know, and I looked at the study. It was an observational study. These people were in a hospital. They were kids in a hospital, so that wasn't a representative of the population that I see in my family medicine clinic, who, you know, the child might be running around well, but may have a runny nose, but mum says, is it safe to give Nurofen? So you can't draw conclusions about that. So I stated that you continue with paracetamol first line, and if the child is not improving, then you can give them Nurofen. And it always has been a role, and that's always the guidance, international guidance on that. The BMJ caused me a few sleepless nights about 2 days after, and they came out with a statement saying that ibuprofen should not be used for managing symptoms, say doctors and scientists. And if you look at this, this was on 17th of March, St. Patrick's Day, right? Or St. Patrick's Day. And oh my God, I was there, my God, how you question yourself, because how did I miss this if the BMJ are publishing impact factor of over 20, like, you know, one of the best journals in the world. Anyway, the EMA came out the following day and stated that there is no scientific evidence establishing a link between ibuprofen and the worsening of COVID-19. The WHO agree and the FDA agreed with that. So the statement was that ibuprofen still has a role in pain and fever in mild symptoms, second line to paracetamol. The BMJ then actually, it was we had responded to initial article questioning why would they publish something, because the patients were coming into our clinic showing me the BMJ article stating that we shouldn't be giving Nurofen. So the BMJ then published an article on the BMJ, and I have all the links, and you're going to get all these links as well, on the 17th of April, and it said ibuprofen can be used for symptoms, say UK agency. So they retracted what they had initially stated. And then the Drugs and Therapeutics Bulletin, literally only a week or two ago, published and stated that they found insufficient evidence to establish a link between the use of ibuprofen and contracting or worsening of COVID-19. But it goes back to first principles. Just go back, and if you looked at the study, you cannot generalize. You can't make a claim against a group of drugs based on a single observational study. And it just shows that if even with a journal with the impact factor that BMJ has, that they dropped the ball on that as well. And I think it caused a lot of unnecessary panic for people that were already very worried. They didn't want to go to the doctor because they were told to stay in at home. And you have to rely on these good journals at a time like this, and that's where I was very disappointed. But anyway, so look, we moved on, and you'll see the next statement here is that do not stop ACE inhibitors or ARBs in patients with hypertension, post-MI, or heart failure. Okay, and this is from the Saudi protocol a few days ago, and I'm going to give the background to that specific statement. So renin
just a question. It was just a question came in there on the chat about,
no problem,
because you're talking about studies there, and
yeah.
This doctor would like to know, you were talking about studies and how we need long-term outcomes, and they're just questioning, during a pandemic, when people are conducting urgent studies at an urgent time like this, what's an appropriate long-term time frame, or how do we judge things that are all done in very much a hurry at the moment?
Yeah, that's a really good question. Okay, to be honest with you, we have never seen this before, like a pandemic like this before. Not obviously not in my lifetime anyway. You will never get the long-term, even with this vaccine, we see that you have to follow a drug for years. You see how long NSAIDs are around, and that then their use were questioned. The point with the study, with the studies that are published, is that you have to go with the best available evidence and the best available study. What you'll see with a lot of these antivirals is that when a study is initially done, you have to look at the primary outcome first. What is it? You can't say that, like that person made a very good, or it's a very good question, because you can't say, oh, will the person be well in 6 months? But then you need to get it published out for the greater good. But my point when and you're going to see each one of these studies, the primary outcomes are not going to be that lengthy. As time moves on, we're going to have better primary outcome measures, okay? And that's the very nature of this pandemic, because every day we're getting more and more data, and that's how you're seeing more publications by the day. But if you ever are going to change normal management, just have a good evidence base for that, i.e. if you're going to stop NSAIDs in a whole group of pediatric population, but base it on one study where, you know, it is an observation study, that's not good. If you're going to mass prescribe a drug to a population, you need better long-term outcomes than a week, you know, than 7 days, and PCR virus status is 7 days. So it is not, obviously, it can't be done that you have a great lag period between exposure of the drug and primary outcome during this pandemic, but just be aware of the primary outcomes, and that's the main point there. You know, so you are right. Ideally, you'd love to have a follow-up of 6 months to a year to see, you know, even when you put a person on, I'm talking about RAAS inhibitors, when you're putting a person on an ACE inhibitor, that takes about 2 months before the blood pressure comes down properly. But the point is that just be skeptical about new drugs coming out to treat any particular condition, but specifically COVID anyway, because the long-term outcomes aren't there, you know. So I hope that kind of answers your question. So it's ideally the longer the better. It's not always going to be possible here, but if you're going to start prescribing a certain medicine, just be wary. Just know the side effects, and obviously, above all, do no harm. And unfortunately, this is what has happened in some of these patients. You know, so is that okay?
Yeah, thanks very much, Paul. That's great.
No bother. So there was a letter to so just to go back to the reason why I'm talking about this is that in this statement here, it says do not stop ACE inhibitors or ARBs with people with hypertension, because there was patients coming into our practice stating, geez, am I safe to continue my ramipril or, you know, my ACE inhibitor? And the basis of this was that there was a letter to the editor of the Lancet in March 2020, and it questioned, all it did was questioned if ACE inhibitors or ARBs increase the risk of severe COVID infection, because we know from a pathophysiology point of view, how does SARS get into cells? It gets into the ACE2 enzyme on the cell membrane. In people who are on ACE inhibitors, you have an upregulation of this ACE2 enzyme. So theoretically, it could increase. There could be more COVID go into the cell membrane and then have an effect. And then that was retweeted and WhatsApped and all these social media outlets. And the bottom line was that you will do a lot of harm by stopping a patient who is, we say post-MI, by stopping a person on their ACE inhibitor, or if they're on it for hypertension, if you stop the ACE inhibitor, which has been shown to reduce the risk of stroke or reduce the of having a second MI. So you could do a lot of harm by stopping the person's ACE inhibitors. The European Society of Cardiology on the 13th of March, thankfully, came out and stated that they dismissed this as there was no sound scientific basis. And the New England Journal of Medicine suggested that there's no change in our approach. And if anything, it can be protective. Okay, so for in the majority in patients with COVID, even if they're in ITU, it can actually be protective. So vitamin D and COVID.
Dr. Paul, it would be why if we keep our patient controlled on hypertension and in these days. So advise them to be compliant on the medications and give them even more drugs if they are not controlled. I think what I read in the literature that hypertension is one of the risk factors for increased mortality for the COVID.
Exactly. I mean, it's one of the main risk factors. Age and hypertension are one of the main risk factors for COVID. So the older you get, and if you are hypertensive, the more you are at risk. So this is why ACE inhibitors, it's so critical that they're, that the patient is on them and continues to stay on them. So yeah. So yeah, no, that's that. Now vitamin D and COVID. So just to talk a bit about vitamin D, there was actually in Ireland, and these studies were well published. They gained a lot of press throughout the world in the last few weeks. So on Friday, the 3rd of April, there was 3 reports on how vitamin D may protect against COVID-19. Okay. 2 reports aligned with national or international guidelines on vitamin D intake. The TILDA study is a very well conducted study, and it's the Irish longitudinal study on aging, and it gave strong evidence for supplementing 10 to 20 micrograms daily of vitamin D. Okay, and this was 400 to 800 international units. This was pre-COVID. This is not even to do with COVID. This study has been going for years, and it showed that a lot, up to 2/3 of our elderly population, are vitamin D deficient, so that they should actually be actively prescribed vitamin D if they can't get it in their diet or from the sun. So Malloy et al., actually, who has published a lot of studies on vitamin D, they advise 5 micrograms of daily vitamin D in breastfeeding children, but caution high dose vitamin D. There was a 3rd report published on the same day, and it stated that every adult, regardless of status, even if they're healthy, should take between 20 and 50 micrograms daily of vitamin D to protect against COVID. Now, this was the study that I had an issue with, because it goes back to basics. In order to make a claim like that, you have got a cohort to the population. The ideal situation for you to show the efficacy of a drug is to have a cohort to the population with a specific condition, so i.e. with COVID. From that cohort to the population, you randomize them, and you give one cohort, half the cohort, vitamin D, and you give the other half the cohort no vitamin D, and obviously you match the 2 groups so that they're the same age, and that so that they're very similar. And then you follow them up. So you analyze, you randomize, and then you analyze, and then you make a statement, and then you can say, well, look, the group that got the vitamin D did better with COVID, and the group that didn't get vitamin D, did worse. Very, very hard thing to do. So I'm making it sound very easy. It's a very difficult thing to do, because it requires a huge amount of effort and time and money and all that to properly run these randomized control trials. But only after doing these trials can you make a statement like that. Okay, so this report did not provide evidence from randomized control trials on benefits of between 20 and 50 micrograms of vitamin D. Okay, and there has been a number of randomized, properly controlled trials called there was one, the VITAL study, the VIDA, the D2D, and the VDART, all freely available, and it showed that the high dose vitamin D did not show benefit. So it's not an evidence. You cannot say to patients, the more vitamin D, the better. It's not there is no science behind that statement. There has been, and also the main issue was that it did not include recent guidance from international bodies. Okay, now what international bodies right across the world state is that 10 microgram daily for healthy adults with minimal sun exposure, and 20 micrograms daily in elderly. Those are the dose, and that's it. Okay, and they're all in agreement. It's the SSCN in the UK, and it shows that the 10 micrograms daily in those with minimal or no sunlight exposure was sufficient to ensure adequate vitamin D status. Okay, and it's the EFSA in the EU, the NNR in the Nordic countries, and IOM for USA and Canada. And these are all in agreement that 10 microgram for healthy adults if you do not get enough sun, and 20 microgram for elderly if they can't get it in their diet or from the sun. And then 5 microgram of vitamin D daily in breastfed infants. Okay, so a lot of the formula feeds now have vitamin D incorporated into, but especially in Ireland, there has recently doubled the amount of vitamin D just only a few months ago. But in people that are breastfeeding their children, they need 5 microgram. The infants need 5 microgram vitamin D. So it's actually under EU law, vitamin D is it's under the EU food law, a 50 microgram of vitamin D supplement can contain anywhere between 40 micrograms and 75 microgram of vitamin D. So this is in contrast to a medicinal product where, for example, Ramipril, where if you state on the label 5 milligrams of Ramipril, well, it has to be between 4.8 milligrams and 5.2 mil. It has to be very precise. Whereas this is, it can be between 40 and 70 is more of a wide range. So you can overdose the patient by prescribing it in error, especially, you know, if they're getting it elsewhere. There's no claims authorized, and this is the main point about vitamin D. There was no claims authorized in the EU for a reduction in risk of infectious disease through vitamin D intake. So up until now, there has been no studies to show that by giving a person vitamin D and following them up, that they are at less of a risk of any infectious disease, okay? And remember, there's 3 sources of vitamin D, which wasn't mentioned in the McCartney et al. Study. Number 1, sunlight. In Ireland, it's between April and October. Food, so most ready-to-eat breakfast cereals, milk, salmon, trout, mackerel, tuna, these are all full of vitamin D. And then the final one then is supplements. So if you're not getting it in sunlight, if you're not getting it in food, then you can take with supplements. So in conclusion,
for that, we have some questions. One of them, so the recent recommendation for vitamin D has nothing to do with COVID prevention?
No. So the recent guidance in vitamin D was based on studies that show that a lot of us are vitamin D deficient, okay? But are not to do with, the studies do not show, there isn't a well-conducted study to show that if you give a population vitamin D, mass supplement every vitamin D, that they will be at a lower risk. There is no study to show that.
Mm-hmm. Okay, the other one, she wrote, in summary regarding vitamin D, it doesn't protect against COVID-19, right? But it is important to treat deficits in patients.
Yeah, she's right. Exactly. Yeah. So yeah, they're correct.
Good.
Okay. So there's a high. Oh, go on. Was there another question?
No, go on, please.
Okay.
No
okay. So there's a higher. So, and as you mentioned, Ahmed, in elderly, by the fact that you're elderly, you're at higher risk of serious illness. So the elderly and the elderly are more likely to have inadequate vitamin D. So people, and the Tilda study showed that, but studies across the world show that as well. Frail, housebound, and greater than 70 years of age, they need 20 microgram of vitamin D. It's reasonable to recommend 10 to 20 micrograms daily if they are not taking fortified foods, milk, salmon, or trout, but there's no evidence for higher amounts. So people that are healthy 55-year-olds to elderly, if they're cocooning and avoiding fortified foods or fish, they may need the 10 to 20 micrograms or 10 micrograms of vitamin D. And that's it with vitamin D. Now, I'm going to just talk a few slides on lithium. Well, one slide on lithium and one slide on DMARDs. So can lithium levels be postponed during the pandemic? So we know that normally our patients come into us a few times a year for lithium levels, okay? So now, what about the patients that are nervous about coming into us? Is there any guidance to say, do you know what? You're okay for a few weeks. We don't need to do your lithium levels this month, but we can do it next month. So I suppose my question to ye is that before we talk about postponing lithium levels, what about if, sorry, I stopped sharing now. So what are how many times a year do lithium levels normally need to be taken in stable patients? So this is just as per, we say, the NICE or international, general international guidance.
Where is the poll, Dr. Paul?
It should be there now. 51% have voted. Have voted so far. Ahmed.
It should come up in front of the screen for you, Ahmed.
Oh, clear. Okay.
Very good, very good. So yeah, 60% of you vote. That's very good. So basically, it's every. So I'm going to share the results. So it's 4 times a year. I always just remember my 4 fingers. So it's 4 times a year. So it's every 3 months. Now, in some patients, that if they are stable, some guidance state that it can be every 6 months, but the majority of patients every 3 months. So it's 4 times a year. Okay. So now if you so normal lithium monitoring, so lithium levels every 3 months for the first year, and then every 3 to 6 months then thereafter. And that's for the Medicines Management Program Ireland, which is in agreement with international guidance. Because lithium levels can cause hyperthyroidism or hypothyroidism, you'll need to do TFTs every 6 months. Renal function and weight check as well. People can put on weight when they're on lithium, and also because lithium is secreted by the kidneys, it can, if your kidney function goes off, you need to dose reduce, so you need to monitor renal function. Lithium, we know ourselves, is in batteries. It's one of the main components of batteries, and lithium is a monovalent cation, which means that it's very similar to sodium. So if you look at the chemical formula of lithium, it's Li, lithium plus, 1 plus sign, and sodium is the same. So your body actually treats lithium like it does sodium. So what you'll find is that if you put a person on a drug that gets rid of sodium, in your body, your brain actually thinks, oh my God, I better hold on to more sodium because I've lost some sodium, i.e. if you put them on a diuretic. But what it does is that it holds on to lithium, so you can become lithium toxic as a result of a person being starting on a diuretic if they're stabilized on lithium. The same thing can happen if you start a person on an ACE inhibitor or an ARB. So just always be careful with that. So there's guidance, and it was updated only a few weeks ago by the Regional Drugs and Therapeutics Centre, and it said monitoring intervals can be extended by up to 1 month during COVID-19. Okay, unless the patient is elderly, if they're over 65, which means you assume there's a certain degree of renal impairment, unless they have a renal impairment, an eGFR less than 60, if they have an impaired thyroid function or calcium level at the last test, lithium can cause your calcium level to rise. If you introduced or removed NSAIDs since the last blood test, because NSAIDs decrease your renal blood flow and can, because they cause a decrease in renal blood flow, it puts off your renal function, which can increase your lithium levels. I stated already about ACE inhibitors, ARBs, and thiazide diuretics. They can actually increase the lithium levels because of the fact that they get rid of sodium. Or if the last serum lithium level was greater than 0.8, so the normal lithium level is 0.6 to 1.2, but obviously if it's greater than 0.8, it's the higher end of normal. So that's lithium levels. So during this pandemic, we can extend it by a month. So can the monitoring interval for DMARDs be postponed during this pandemic? And yes, it can. But I suppose just to run another poll here again, sorry, I'll stop sharing this one and this one. So with so how many times a year are bloods normally required in patients taking azathioprine? So it's known as Imuran in Ireland. And this is actually the same for Methotrexate, same for Mercaptopurine, Azathioprine, Penicillamine, for a lot of these DMARDs. What would the general rule be? So I love it. Yeah, the majority of you are Yeah, you're good. You're good. So it's, I'm going to share the results. So it's every 3 months. So it's 4 times a year again. Okay. So it's just remember 4. Okay. And it's every 3 months. And I just stop sharing that now. Now with this, so methotrexate, leflunomide, which is Arava, is azathioprine, Mercaptopurine, or Penicillamine monitoring. If there's on current DMARD treatment for greater than 12 months at a stable dose for greater than 6 weeks, you can consider extending the monitoring interval by up to every 4 months rather than usually every 3 months. And the normal bloods you need a full blood count, renal function, and liver function tests. Unless if the patient has a CKD, chronic kidney disease, greater than 3, which is an EGFR 59 mils per minute or less, or they have liver problems or previous abnormal white blood cells within the previous 3 months. So the majority of our patients won't have this. Yeah.
Is there any recommendation for the thyroxine monitoring?
So yeah, so usually that's it's usually every year, Amit. So that's why it's not. So obviously, if the person is starting off, they'll need it more often. But people that are stable on your levothyroxine once a year is fine. You know, so that's why there hasn't been any guidance on that yet. I've no doubt in the next few months, as this pandemic stays with us, there may be some guidance to state that you can prolong the interval. But because it's not, it doesn't have to be done every 3 months. Because it doesn't have to be done every 3 months, there's no recommendation to increase the monitoring interval. I've no doubt it will, but there's nothing yet, Anya, to answer that question, Ahmed.
Okay, so it will be continue as the same, no change.
Yeah.
For the
no change. Yeah.
Okay.
So
I can understand till now for us as GPs or family medicine, we can only prescribe paracetamol in this COVID.
Yeah, it's interesting. It's interesting that and I hope I'll cause controversy now. You won't have me back again. But no, you're actually good. Like I respect the BMJ for republishing another article to say, and because I was actually very frustrated with the BMJ. I said, why would you do that? It was lazy journalism in my sense. That's what it was, because they didn't look at the evidence base. And in fairness, they published my reply to it, giving out to them. And so I respect that they actually had the decency to publish it again. But I think that so the world feels that there's no problem. Now, for the patients that we see in primary care, like obviously people that are in intensive care unit, who are fluid depleted, the old rule is you never would put them on an NSAID. And that's not the cohort we're talking about. We're talking about the cohort in primary care, the child coming in who's off form. There is no problem, and there has been no worry whatsoever. And everyone has, the main issue is the BMJ publishing it, but nobody else had published it. So. But yeah. So remdesivir, you mentioned yesterday, Ahmed, that you'd like to see what the Americans and different other countries are the drugs that they're talking about. So I've circled because we've mentioned remdesivir, and I'm just going to talk for a few minutes about it. The background is it's a nucleoside analog. It's like azathioprine or mercaptopurine. It was developed in response to the 2015 Ebola outbreak. It was no good. It did not work for Ebola. Okay, it was an investigational drug. It's not FDA approved for any indication, including COVID-19. It did receive an emergency use authorization for COVID-19, which means it's a lower bar. Usually for the FDA approval, you need a higher efficacy to show, evidence-based to show it. But during COVID, they have an emergency use authorization. Because it's a new drug, it's little known about its side effects, okay? Now, we will not be prescribing this in primary care. This is only just, and even the protocol you sent me, it's in secondary care, okay? There was 2 RCTs. Now, I've got the link to a very good handbook on an international handbook on all of the treatments for COVID. But there was 2 RCTs. And what it did, it showed that it accelerated recovery by 1 to 4 days. So what does that mean? Right? Question, what does that mean? There was no robust evidence that remdesivir improves mortality or affects long-term outcomes. Full stop. That's it. It doesn't. There is nothing to show it. Okay. The larger study showed that there was a possible reduction in mortality after 2 weeks, but it was only over time this mortality may dissipate. They don't know. Okay. So that's as of this morning. Okay. So the lopinavir or ritonavir, this is actually this was only published there. This was only published May 7th. It was updated on May 7th. And in hospitalized or adult patients with severe COVID-19, there was no benefit was observed with lopinavir or ritonavir treatment. No benefit. Okay. So now if you see here the pharmacotherapy, you'll see that it's a triple combination as per your protocol. So this is interferon beta 1b, lopinavir, ritonavir, and ribavirin. And this has shown slightly more promising results than the lopinavir, ritonavir. And this was published in the Lancet literally just a few days ago. And what it stated was, it was 2 days ago, and triple combination of it, what it thought is, the study showed was that early triple antiviral therapy was safe and superior to lopinavir or ritonavir. And remember, I said the lopinavir or ritonavir may accelerate improvement by 1 to 4 days. These drugs are very expensive, but it was safe and superior in alleviating symptoms and shortening the duration of viral shedding and hospital stay. So shorten the duration of viral shedding and hospital stay with mild to moderate COVID-19, but future clinical study of double antiviral therapy is warranted. So it did not show that people reduce mortality. Okay, so it's just to bear that in mind. Okay, that these drugs are expensive, and we won't be prescribing them in family medicine in Ireland. They're our secondary care colleagues, but just that you asked me to look at what the Lancet and these are saying, that there's not a huge, and because it's in the protocol, I said it. These are the ones to kind of keep more of an eye out for. We do know that there's an COVID-19, there is a cytokine storm. So you have this intensely pro-inflammatory response, and this leads to the, procoagulant state and that's why there's mention in the enoxaparin and that in your protocol. But the bottom line, there is no well-established or evidence-based treatment for cytokine storm in COVID-19. Possible options include high-dose steroid, tocilizumab, IL-1 inhibitors such as anakinra or JAK inhibitors. We don't know, so, to be honest, and I hate to be pouring cold water on anyone that says that this drug is great, but anytime a person comes out and says that, just question it. That's it. That's it. So I hope I haven't went too fast. Or
No, it was nice, like before. Thank you, Dr. Paul. We have here a question about the ribavirin and Tamiflu. What is the role of those two drugs now in the COVID?
So it was used. So the best available evidence for that, for ribavirin, is as triple therapy. They weren't shown to be good on their own, but as triple therapy, it just alleviates symptoms and shortens the viral illness, may shorten hospital stay. It's very early days. This is our long-term outcomes type data I'm talking about. This is where we'll be able to say in about 6 months' time whether they're good or not. If I was to be, I know I can be quite cynical about drugs used for new conditions, but in my experience, we look back in 6 months and these will be off. I don't think that you say yourself that it's updated daily, and I can't see them being very efficacious, if I was to be honest.
I suppose, Paul, what the individual was talking about really is what they're saying is that when patients get to the point where they have infiltrate in the lungs and they're intubated, that they're often the outcome, as we know, isn't terribly good. So they were just wondering, is there any benefit in starting?
Yeah. Well, Yeah, exactly. So this is where this kind of comes in. So when the patient is, but the whole point, what you want, and this is over the last few weeks that they've seen, is that it's to do with this cytokine storm, this really intensely pro-inflammatory state, and you need to get in with these drugs before a lot of time when they're intubated and when they're at the procoagulant state, as you mentioned, that it's a bit late for these drugs, but they're not finding these drugs as good as what they thought they would be. Do you know, even your interferons and that, even though they're good and they will reduce, we're just learning about this illness. We really are, you know, so.
Someone else is just asking about somebody with an asthma exacerbation. Should they have systemic steroids?
Oh yeah, not a bother. So with asthma, and same with COPD, I always say, is it prednisolone you have in Ahmed in Saudi, or what's your corticosteroids?
Yeah, we have systematic and.
Which ones do you use? What names do you use, Ahmed? There, what is it? Prednisolone, or what would you be using?
A systematic steroid.
Steroids, yeah.
Yeah, we have all the brands. There is no problem. It is just most likely prednisolone. This is the most likely.
Yeah. So basically, for asthma exacerbations, I would usually go, and as per the NICE and the SIGN and the BTS guidance, it's 40 milligrams once, like for an adult dose, 40 milligram once daily for 5 days. So there's no evidence base to state that either with COPD or asthma, this is prior to COVID, that you should get any longer. You should not give them 6 or 7 days, you know, of a lower dose steroid or anything like that. And the issue during COVID is that if you use the steroids for greater than 7 days, well, then they are at an immunosuppressed state, and you do not get you do not get benefit. So to answer that question, I would do, as I've done prior to COVID, I would put them on 5 days of a 40 milligram once daily oral steroid early in the morning, obviously to try and reduce the awakening at night. But that will not change. And also with the inhaled corticosteroids, no problem in the world. Low dose inhaled corticosteroids, step 2, and then add in a LABA step 3, and a Montelukast then after that. So there's no change to management in COPD or asthma.
Somebody else is just asking about more straightforward, simple, just symptom relief in people maybe with milder symptoms. So is a cough syrup any good for those with cough? Is a nasal spray, normal saline spray any good? Just those kind of things, yeah. Are they useful?
Yeah. I do as I do prior to COVID. I treat them the same way. So to be very honest, there's little evidence base to use cough syrups, okay? And there never has been a great evidence base. But I always say risk-benefit ratio. When they come in and see you, they want some kind of a treatment. Even honey has been shown. Honey has a great evidence base actually for cough, even in kids, because when you have a cough, when you have an RT, like a lot of coronaviruses that we pick up, you've got pro-inflammatory state in your nasal mucosa. You've got a lot of lymphocytes and you have this post-nasal drip. So by using the nasal sprays, number one, it won't do any harm, but as long as you don't use any of these nasal sprays, these oxymetazoline or pseudoephedrine nasal sprays for any more than 4 days, I wouldn't do it because you get rebound nasal congestion. But I definitely would still use the nasal sprays, be it normal saline or the topical decongestants. There's very little evidence base for them, but you won't do any harm. And the second thing, I would use the cough bottles, and if they have myalgia and they feel if they're kind of rheumatic type pain secondary to the flu symptoms or the RT symptoms, I'd have no problem in giving paracetamol. And if that's not helping, then I'd add in Nurofen then as well.
But I think there is no evidence for. I just want to stress on this knowledge that there is no evidence to use cough syrup in COVID or before COVID or with no COVID at all. There is another question regarding giving azithromycin and aspirin for symptomatic suspected cases before confirmation.
no. The reason why I would not give either. The reason why I would not give azithromycin is because it prolongs the QT interval and the person may get a ventricular tachycardia. There is no, and the second thing is that it has not shown to be effective to reduce the severity of COVID. With aspirin works on the venous system, so it stops clots in your venous system, but it's actually, COVID causes more of a procoagulant state in the arterial system. So this is why, you've got your apixaban and that are used, and as well as your low molecular weight heparins. Aspirin does not reduce, has not been shown to reduce mortality with, with at the stage when you are in primary care referring in. So I wouldn't go there.
Do you think, Dr. Paul, that the new evidence now goes with not to use antibiotics during the COVID-19 as they may increase the mortality and morbidity?
Azithromycin, definitely not to use. But if the person has got a secondary pneumonia after getting a viral RT or after getting a viral LRTI, I have no problem in giving penicillin antibiotics. There has been no increased risk of mortality from giving a person an antibiotic, but I'd only give it if I thought they had a bacterial infection. I would not give it for a viral infection.
Sure. Yeah, not for the COVID, because some people, they are just giving antibiotics when patient comes with upper tract infections and they are not, they don't know the real diagnosis. Okay, I will go if the patient has pharyngitis and seems to be bacterial, I would give antibiotic. But just for upper tract infection, which seems viral or suspected for COVID, will not go antibiotics.
No, and even if you're talking about upper respiratory tract infections, if you look at the guidance, even for an acute sinusitis, there's only benefit if the person has symptoms for greater than 10 to 14 days. So even if they have your nasal, your upper molar tooth pain, and they've got a lot of nasal discharge and really tender there, there's no evidence to start an antibiotic prior to 10 days. It's 10 to 14 days. Then they can be put on amoxicillin or doxycycline. But there's even if so it's that's yeah.
Good. They want to know your opinion about vitamin C to be given as prophylaxis.
Yeah,
and also somebody else is talking about zinc as well. Paul is
So this is where I'll be honest with you. So there's very little evidence. It's always risk benefit. There's very little evidence for vitamin C or zinc, but you're not going to do much harm by giving them vitamin C or zinc, unlike the azithromycin or the Plaquenil. Okay, or so if you give a cough bottle, if you give zinc, if you give vitamin C, you're not going to do harm. Okay, there's very little evidence based. So I would, if the person really wanted it, I would, but I would not go out of my way to prescribe it. So if the person felt that it would improve, I have no problem in saying, okay, buy it. So, but I wouldn't be actively prescribing it.
Mm-hmm. There's a few more questions there, Ahmed, isn't there? About I think somebody's looking for you to give really to summarize. I think you've done it, but to summarize an evidence-based management plan for COVID. So excluding the things that have no evidence, basically. What is there evidence for us to use?
So there are evidence. So what you'll see, it's actually very interesting, even in the protocol that you've given there. It's a very good protocol, okay? And that's the one that it's very similar to the one in Ireland as well. It's like all viral infections. We don't have an answer. We don't have a treatment. We need a vaccine, and obviously there's issues then with the vaccine as well, and the safety of vaccine and all that. An evidence-based supportive therapy, that's it. Well, like any other virus, it's supportive therapy. There's no real great drug. I've showed you. I know that there's a lot of companies would love to come up with the silver bullet or the wonder drug. These viruses were not good as humans at tackling viruses. So the protocol that Saudi has is the standard. So yeah, that's it. That's the evidence base, and it shows how little evidence is behind some of even the recommendations. But that's all we have to go on.
Okay, nice. Thank you so much, Dr. Paul. I think so. We don't miss Dr. Nada.
Yeah.
I think you have some experience with the COVID-19.
السلام عليكم.
السلام عليكم. هلا دكتورة. حياك الله.
Eid Mubarak. Well,
Mubarak.
for the last 6 weeks, I'm seeing COVID confirmed patients, and we noticed a few things. I would really like to share my experience with you guys. Maybe it help you. It helps. Several things that Dr. Paul explained during the presentation. Thank you, Dr. Paul. Well, I noticed that for diabetic and hypertension, when you continue same medication, nothing is affected. Nothing happened. No worse symptoms. No less symptoms. But what I noticed really that's improved their symptoms if I get them out for this exercise, like 5 minutes, exposure to sun, more better ventilation. In the last week, I'm starting to vitamin D 1,000 units a day for 4 days or 5 days. I notice very fast improvement, like if the symptoms, especially those with fatigue and anosmia, they are totally having this fatigue and loss of energy. When you start vitamin D, like after 2 days, they improved. I noticed also at the beginning of this experience that when they are just sitting in the room with the low ventilation, the duration of mortality is high. Like if the symptoms should stay like 4 days, they presented with the symptoms, especially headache and cough and sore throat for 8 days rather than lessen the duration. But when I told the group that let them go out and expose to sun and exercise, I noticed the difference. Like the duration of morbidity become less, like it's become like 2 to 3 days, and then they improve and they look like a healthy person. For those with the asthma and they need Ventolin, we use only inhaler. We don't use nebulizer. Brilliant. Due to the infection control, we don't spread this infection during the and also prednisolone. I'm using prednisolone for this patient if needed, but not the same dose as prescribed, but I reduce it a little bit. Also, Ibuprofen, I use it for many of them, which they are not responding to paracetamol, they improve. But after Ibuprofen, they feel like more lost energy. So these are all observation on patient. I have 800 in Dammam and 1,600 in Jubail. Also, we created a scoring system after doing extensive literature review to classify these of mild cases and those who need observation in outpatient clinic or in urgent care, or those who need immediate transfer to hospital because we suspect that they need ICU. In the last 2 weeks, I overcome like 963 patients. We refer according to the score that we generated. We refer 19 patients, and the average is around 1 to 2 patients per day. This is really helpful. And those patients, when we follow them up, we notice that they have bilateral in the chest X-ray. They have bilateral infusion, and they have pneumonia and community acquired. Also, this score was applying in the ER in our COVID hospital, and we noticed that those patients who are entering ICU, they usually have abnormal sodium, low sodium, and high BUN. And not only that, they respond better to ceftriaxone. And sometimes you can combine ceftriaxone and azithromycin. We don't give IV unless this patient he cannot take by oral. We give oral hydration and they are improved. It depends on the severity of the symptoms and the risk factors. It was a rich experience, and like every day you know the disease well. Now one of my colleagues, he told me, do you want? He's thinking, is it important that I take a swab or not? When he explained the symptoms, I told him, sorry, you are typical one of my patients in the quarantine, and I think if you want to take it, it's up to you. But it's better to make sure that you don't have any shortness of breath, and eat healthy diet, ventilation, make it good. And I give him vitamin D and folic acid. And this is strange. One of my patients, we are giving him paracetamol for 3 days. This is at the beginning of the crisis, and it never improved and never responds to paracetamol. And one of my colleagues, he's from Sudan, and he told me that if the virus respond to chlorothiazide, why don't I give folic acid? I told him why. He told me because the process of the virus, it comes inside the white BCs and infiltrated and destroyed, then inflammation comes out. So, and the similar mechanism happened with those patients with malaria. So we started with the paracetamol regular. We started folic acid, and after like 1 day, 2 days, the temperature was become normal. This virus is really strange, and with time, you get the skill that ill patient who must be go to the ICU, or those who's they are suspected when most likely they are negative. These symptoms are not atypical. It cannot be. And the symptoms that the description of the patient, like every patient is a textbook. The description of the patient of the symptoms by the patient has become similar. Like the type of headache, they said it's heaviness on the one side, unilateral, not the whole headache, whole head. Also the loss of sensation and loss of taste. These are considered common symptoms. The diarrhea with the special nature, they explain it's not watery diarrhea. And also this gives you kind of information about the virus. I want to share my experience, especially you are tackling this topic, and I would really thank you that you are giving us this information with evidence that will support our practice. Thank you so much, doctors.
Thank you for sharing. Really, very interesting. Very interesting,
yeah. Right?
You're very busy there down in the east, Nada, huh?
Yeah.
Oh my God.
Yeah.
Okay.
So Paul, we have a lot of complimentary messages coming through in the chat, just to let you know everyone appreciates the content and said it's just the right time and the right content. So thank you for that. Are there any more?
I love it, and thank you for having me. Thank you. I love talking about this. I love talking about drugs. So yeah.
I think that's all the questions, isn't it? There's just thanks coming in, both for you, Paul, and for Dr. Nada for sharing her experience with us, which was also wonderful. Thanks. Yeah.
You're on mute, Dr. Ahmed.
Dr. Ahmed, do you want to wrap things up?
So we are coming to the end. Thank you all guys for your attendance, for your participation, for the nice sharing of information and experience. Great thanks to you, Dr. Paul, for your nice and wonderful lecture. And thank you, my colleagues, Dr. Molly, Dr. Tom, Brian, and everybody. Dr. Nada, thank you for your sharing. Thank you all, our audience, great residents and trainers, and we hope that we see you again in the next webinar. So see you again, and goodbye for everybody. Thank you.
Bye. Thank you. Bye.
Thank you. Thank you,
Thank you.
everybody.
Paul, thanks, Ahmed.
Bye. Thanks,
Bye now.
Thanks, Brian. Bye.